Hi, my name's Danny Ahmed. I'm one of the clinical partners at Foundations. Thanks very much for this opportunity to come along, speak to you all today. Unfortunately, I couldn't be there in person, so we've done our very best with this video. So I hope it gets the messages across that I intend to. A little bit about me. My background is in mental health nursing, and I'm also a qualified integrative psychotherapist and one of the clinical partners at Foundations. Foundations is a specialist GP practice that operates in the Middlesbrough area. We provide a number of services, one of which is to support substance users and their clinical treatment. We're also their GP practice so that we can support them with any of the health needs that they may have, and that puts us in an ideal position to support people who are particularly vulnerable and frail. We also provide services for individuals who are seeking asylum within the UK or seeking refuge at our sister practice. We also have the contract for the SAS, which is an unusually named contract, but it's effectively to support individuals who have been had their access to primary care limited due to violent or aggressive behaviour. So we work with those individuals to support them back into mainstream practice effectively. As I mentioned, one of our operations is around supporting people with substance use issues, and we do that as part of MRT. MRT stands for Middlesbrough Recovering Together, and it's a partnership of organisations that's been brought together through public health. So there's Foundations, as I've talked about, and we work alongside our partners CGL, who are responsible for the care coordination and psychosocial interventions of individuals with substance use issues, and another local partner, Recovery Connections. And Recovery Connections deliver support services through the quasi-residential rehab and are a service user-led service, so they're encouraging individuals to get into meaningful recovery and stay into meaningful recovery. MRT as a treatment system works with anybody across the whole system, whether they are in active substance use or at the very end of your substance use career, in want of a better word. Our aspiration as a treatment service is to support individuals to get into meaningful recovery and to be abstinent from drugs and alcohol. Where MRT takes a very proactive approach is it recognises some of the issues and the complexities that individuals are struggling with and works with people no matter where they're at in their journey. So if you continue to use substances, MRT has got a treatment offer for you. And an example of that is how that we have rapid access to treatment for individuals. So most places in the country these days have a number of weeks waiting time to access treatment for drug or alcohol problems. Within the MRT model, you can effectively access an assessment and the key intervention, such as prescribing, within an hour. So that's an amazing way that we're able to respond to individuals as quickly as we can. So one of the most alarming and significant issues facing substance users currently is the increasing rate of drug-related deaths in the UK and locally. 1 in 3 drug-related deaths in Europe happens in England, and it's more likely to happen in the northeast of England and in the heroin-using population. So it's happening right here and right now. It's happening to our community, and this is somebody's mother, this is somebody's brother, this is somebody's son who is unnecessarily dying from a drug-related death. Rather harrowingly, you're more likely to die from a drug-related death in Middlesbrough than from a car crash, and I think that's just a horrific statistic when you think about the context of that. And I think more alarmingly is that this is now a public health emergency, and we're focusing on this issue as though it is a public health emergency. There was a recent report that came out a couple of years ago by the Advisory Council of the Misuse of Drugs, and they talked about heroin-using lifestyle being associated with premature death and being associated with significant collateral damage. And I think that's just a really powerful term when you consider that that is discussing somebody's lifestyle in the terms of significant collateral damage. And given that we work with individuals and support them with some of their health needs, we're able to look at what that collateral damage looks like from a health perspective. And it's harrowing. The average age of our patients is about 38 years old, but they've got a staggeringly increased prevalence of chronic health conditions. They're effectively presenting with the illnesses of old age. So this population are twice as likely to have asthma they're over twice as likely to have COPD, with the average age of diagnosis being 43 years old, so usually it's about 67. So you've got individuals who are having to try and manage a degenerative illness over a very long period of time. They're over twice as likely to have mental health problems, and that will include issues around problems with personality, difficulties with managing mood and emotion, which in turn increases the likelihood of deliberate self-harm and suicide. And I think it's probably fair to say that I don't know of any patient that I've worked with over the last 20 years who hasn't had some significant trauma in their lives in the background and in the past. Effectively, they're doing the very best that they can to try and manage what was a very difficult situation for them. And I think the more that we understand about adverse child experiences and ACEs, the more clear it is that those early experiences are extremely damaging to individuals in later life. We continue to see high levels of problems with injecting-related behaviour, so DVTs or cellulitis, increasing number of people that are amputees. And we've got one or two individuals who are on our end-of-life pathway, so one is 39 and one is 43 years old. These are young people who are dying. We've effectively got medieval levels of life expectancy in this population, and we need to work together to do something about this. So as we continue to attempt to address the rise in drug-related deaths, because this is not a problem that is going away, and as I've mentioned before, we do need to work in partnership, I'm really pleased to be part of a network of services and individuals who are meeting regionally to start to explore how we can have an impact on reducing drug-related deaths. And I think one of the areas that it might be useful for the Trust to get involved is how we can share some of the overdose data of individuals coming into A&E departments. We know that individuals are overdosing. These are our near misses, but we don't often know until a number of weeks later, and some treatment agencies may not get that information at all. So we're blindly continuing to treat individuals not knowing the level of risk that they might be putting themselves at. We know that your A&E department is incredibly busy and works incredibly well with individual users, but we might be able to work smarter together to prevent people coming in the first place. So I'd like to see that the Trust is able to contribute to the regional reducing drug-related deaths agenda, be part of our focused harm reduction strategies, and be open to sharing information in the hope that we can make a real impact on the offer that we can make to individuals to keep them alive. I want to take the opportunity to raise awareness around naloxone. And naloxone is an opiate reversal drug that we now issue to individuals who are in contact with us in treatment and through needle exchange. What naloxone will do is reverse temporarily the effects of any opiate, so it reverses respiratory depression effectively until further medical attention can be sought. We've worked incredibly hard with our partners and with Public Health's vision to flood the town with these overdose kits. We don't want there to be an overdose without a kit available, and we're getting very near to that point. We've worked with a number of agencies, about 30, and they now hold the kits and have been trained in the use, and about 150 staff across Middlesbrough in a range of organisations have been trained in the use of naloxone. And one of the key partners that we've worked with is the Trust and the A&E department, and we're delighted that you supported us as we had the conversation with you about reducing drug-related deaths, and you now issue naloxone kits to anybody who's admitted with a suspected opiate overdose. I think there's still some work for us to be done, because due to the pressures that you're under, sometimes people get missed. But I think it's important that we've got this piece of work going on, and I know that you're only the second hospital in the UK that has taken this stance in issuing kits, so I'm really proud of the partnership working, but I think there's more that we can do at this moment in time. We're also looking at a number of ways that we can continue to get contact with individuals who are using substances. One of those ways is through peer-to-peer distribution of naloxone. So we're looking at getting active substance users to deliver naloxone out in the community to other service users who may not be in treatment. So we'll effectively give people 5 or 10 kits, and then they will get out there and give the kits to people who need them, who may not be wanting at this time to be in treatment. And we know that this is an important population for us to get contact with, because you're more likely to die of a drug-related death if you're not in contact with a drug service. MRT and Public Health in Middlesbrough have been working really closely with Cleveland Police, and we know that Cleveland Police are planning to carry nasal naloxone kits in patrol cars and in particular units such as the drug squad. And I think what we're really getting towards is a universal recognition that naloxone is a kit that needs to be available as widely as possible. We're also looking at some discussions more widely about whether we can get kits added to defib units and defib distribution points, so that again the public are aware where kits are available and they're easily accessible. We'd also like to see kits available in places like fast food restaurants and bus stations. We haven't quite been able to penetrate those services yet, but I think it's only a matter of time as we continue to raise awareness about the issues that individuals are facing and the vital role that naloxone has in reducing drug-related deaths. One of the key interventions in supporting people, particularly heroin users, is the use of opiate substitute therapy medications, often known as medically assisted recovery. And that's the use of medications such as buprenorphine and methadone to effectively replace the street heroin use that's happening. We follow the clinical guidelines for the treatment of substance use. It's often known as the Orange Book. And the Orange Book is very clear about the optimum way to maximise the benefit of these treatments. And that's about getting the right daily dose. And often over the last 20 years, when I've been having discussions with members of the public or the wider professional field, people can have a misconception about what is the correct dosing for individuals on one of these therapies. The evidence is very clear that if you are on methadone, the optimum range of methadone for the maximum benefit is between 60 and 120 milligrams per day. What you find if somebody's in that optimal range is that they're less likely to die, they're less likely to engage in ongoing high-risk behaviours, such as injecting in complex areas like the neck or in the groin. They're more likely to remain retained in treatment, so continue to have contact with substance use services. And they're also more likely to be in a place of stability to start to look at some of the more complex factors of why they began to use substances in the first place. The equivalent daily doses for buprenorphine in that optimum range would be between 12 and 16 milligrams, and again you would expect to have similar benefits. I think one of the challenges that's happened over the last decade as we have moved to support people into meaningful recovery is there's been a pressure on individuals to reduce that dose of methadone or buprenorphine too quickly, or they've never actually been given the opportunity to get into that therapeutic range. There often seems to be a pressure from either other professionals or from family members to reduce that dose. What we find is that when people reduce that dose, they are more likely to fall out of treatment and increase the risk of drug-related death. So one of the treatment options that we're exploring in Middlesbrough at the moment is an injectable opioid treatment. And this is an evidence-based treatment whereby individuals who are selected will come along to the practice 7 days a week and will self-administer diamorphine. It's a widely used practice within Canada and within the rest of Europe, and it's got some really great outcomes. So we know that when individuals are able to access a program like this, we see dramatic improvements in health, and we see dramatic reductions in the social impact of an individual's substance use. So we're looking at a treatment program like this because the evidence-based medications that I spoke about earlier, it's clear that for a number of people these aren't quite effective. I think it's about 5 to 10% of that population will fail to benefit from treatment. So all those protective factors and that I spoke about earlier are not awarded to those individuals. The evidence is clear that diamorphine self-administered under medical supervision is an appropriate and effective second-line treatment. This will be the first of its kind in the UK since the previous trials a number of years ago, and we're hoping that this will be the catalyst for more services to be developed across the UK. We know our colleagues in Glasgow are moving forward with their programme as well, and that other areas are very interested in the outcomes of our pilot. We'll be exploring between 10 and 20 individuals accessing the programme, and they will come along for 2 supervised doses of diamorphine 7 days a week, but they'll have key wraparound support, so it's not just about replacing the street heroin with another medication. This is about using medication to maximise the most benefit. So as individuals come in and have the dose of medication, they'll then be working with our partners to look at psychosocial interventions, clear care planning, and being engaged with recovery ambassadors. And recovery ambassadors are individuals who have been through treatment systems, are in meaningful recovery themselves, and can give something back, give that beacon of hope that actually life doesn't have to be all about being stuck in substance use. We're awaiting a start date, so we're very close to starting, and we'll of course let people know when that happens. But we're confident that we'll be able to show that for a range of individuals who fail to benefit from treatment, that this is an effective treatment. It's important that we look at interventions like this, because failure to benefit from treatment has a number of impacts for all of us. Firstly, it increases the risks to the individual, as I've mentioned earlier. It increases the risks and the disharmony within families, but it also impacts everyday communities and everyday services. So we undertook an exercise to explore the economic impact of failure to benefit for treatment, looking at 20 cases who would be suitable for the type of programme I'm talking about. What we found is that for these 20 individuals, the economic impact of their criminal activity, so what it costs the police to manage these individuals every time they're arrested for an offence, worked out at £800,000. Now that works out at £5.50 per head of Middlesbrough residents. So each one of us is paying for managing these individuals and the fact that they're struggling to benefit from treatment. We also know that that leads to often short sentences in prison, and that cost for these 20 individuals was estimated at about £1 million. So just from an economic point of view, we're already looking at nearly £2 million from the impact of 20 people failing to benefit from treatment. So the criminal justice approach to managing substance use treatment is failing. I can't put it any blunter than that. Individuals are stuck in a cycle of offending and incarceration with a treatment offer that's not going to benefit them. So we have to do something different. We have to do something different for all of us. We will all benefit if we can help people to stabilise. One of the things that we can all do, and we can all do from the minute this video finishes, is address the stigma that people who use drugs face. And I think it's a really important issue, because we often hear that our patients won't engage with other services, they won't engage in the wider community because of the stigma they fear. I mean, some of the terminology that we hear on a daily basis is quite disturbing and harrowing. In fact, when I've often seen information in the local paper around drug-related deaths, some of the comments that are written by readers are really harrowing, referring to drug users as scum, and that they're pleased that the rate of drug-related deaths is increasing. I think when we talk about substance use, it's often being loaded with morals, and I think as health professionals it's important that we can step away from that moralistic judgment of what somebody is choosing to do. I think one of the ways that I am able to manage some of those emotions is remembering that most people who have got themselves in a difficult position with substances have got some underlying trauma. These are effectively young people who are doing their very best to deal with a very difficult set of life circumstances. Often there may be some sexual or physical abuse in the past, or just mental and emotional abuse that has led them to this solution. So all of us as individuals can do take this very simple principle, and this works for us in Foundations and is one of our core beliefs, that I'm okay and you're okay. And this guiding principle means that we meet people where they're at. They may choose to undertake destructive and difficult practices, and some of the behaviour may be difficult to manage at times, but ultimately I'm okay and you're okay. And I think this type of mindset means that we're able to hold and support individuals no matter where they're at in their lives. I think it also means that individuals will come back and they'll talk to us and they'll feel as though they are respected as the people that they are, rather than being seen as a substance abuser or user, which are some of the terms that can be often bandied around. Ultimately, these are people, these are somebody's family, and we do need to support them by our use of language and by our actions. We hear from individuals that they self-discharged from hospital because they felt the nurses were looking down at them, or they felt that their issues around pain relief were not being managed because they were a substance user. And some of these decisions may be very wise clinical decisions, but maybe the way that those messages are delivered are often taken as a judgment of an individual and their circumstances. So if you don't take anything else away from today, I think if we can have the attitude of I'm okay and you're okay, and that we actually love these individuals and that we care what happens to them, that could be the biggest difference you make to any individual. And that might be the moment where they decide to put their faith back in humanity rather than continue down the road of using substances to avoid the difficulties of humanity. So I implore you to take that message away with you today.